One thing that's underutilized in terms of patients with colorectal cancer is the use of genetic testing to help guide dosing and adjustment based on what mutations or variations may be present in terms of determining what genes metabolize which drugs. For patients with GI cancers and specifically colorectal cancers, we know there are the genes that metabolize the most commonly used chemotherapy, which is 5-fluorouracil or capecitabine. We also know of which drugs metabolize the irinotecan chemotherapy in terms of the gene being the UGT1A1 gene. Historical analysis of studies like the clinical trial has shown that these patients do far worse in terms of side effects when they get chemotherapy and they harbor an aberration in one of these genes. It's underestimated how many patients have this aberration. If you look at numbers, while for DPD alone they're coding numbers anywhere between 3 to 5%. For UGT they're coding numbers anywhere between 30 to 40% and another 10% for homozygous. If you factor in both of them together, you're talking about at least 50-60% chance of having an aberration in one of the two genes. We're presenting some of our early results of incorporating this testing into practice, and it's feasible because now you can get the results back within 3 to 5 days, so you can make a decision real time, because that was one of the barriers in terms of its uptake, in terms of cost, and also how quickly will the results become available. The other barrier was how to interpret these results, but now there are guidelines available that tell you if you have an aberration in whichever gene, how much chemo should you consider in terms of reduction.